room doors, literally gasping for air. The medical team has to act fast, right? But more importantly, they have to think systematically. Welcome to today's explainer on the breathless patient. We're going to dive deep into the exact mental frameworks and diagnostic tools that docs use to save lives when, honestly, every single breath counts.
You know that annoying screen you get when a website runs a security check to make sure you're not a bot? Well, diagnosing breathlessness is kind of like that. An doctor has to systematically run a rigid internal security check to figure out exactly what hidden threat is blocking a patient's airway or blood flow. There's no room for guessing here. They run a strict protocol to hunt down the culprit.
So here's our triage board for this explainer. We'll start by verifying the threat. Then listen for the loud alarms of upper airway obstructions. After that, we'll look into medically unexplained dyspnea, spot the silent threat of pulmonary embolisms, unpack the PE diagnostic toolkit, and finally talk about treating those high-stakes blockages. Let's jump right in. Starting off with step 1, verifying the threat, or what we like to call the security check.
When someone comes in with dyspnea, which is just the medical term for shortness of breath, doctors absolutely cannot just assume it's a lung problem. Before they zoom in on any specific diagnosis, they literally have to execute a full system security check across the entire body.
They're checking for respiratory issues, sure, but they also have to consider cardiac problems, severe anemia, neuromuscular diseases like Guillain-Barré, and even metabolic acidosis. It's a massive checklist. And you know what's really wild? In patients over 85 years old, the most common presentation of a heart attack isn't that classic chest-clutching pain you see in movies. It's actually just shortness of breath. This is exactly why doctors have to cast a really wide net right from the very beginning.
Okay, moving down the funnel to upper airway obstruction sounds, the loud alarms of the respiratory system.
Believe it or not, simply listening to a patient speak is a hugely vital diagnostic tool. Hoarseness, really any rough, harsh, or breathy change in voice quality, gives doctors their very first crucial clue. It immediately tells the physician that something is messing with the vocal cords. But what if that weird sound is tied to their actual breathing?
Well, you have to listen closely, because the difference between obstruction sounds is absolutely critical. If the blockage is high up, above the larynx, you're going to hear what's called stertor. It's this low-pitched, rough, snoring sound. Honestly, think of a sleepy English bulldog. But if the issue is a bit lower, down in the larynx or trachea, you get stridor. This is a high-pitched, musical, harsh sound. And here's the kicker. Stridor is super often mistakenly dismissed as asthma wheezing. But it actually points to a serious upper airway compromise that needs immediate drop-everything action.
Now let's switch gears to something called medically unexplained dyspnea, or the MUD mystery.
Welcome to MUD. This happens when a patient feels this terrifying, oppressive need to take a deep breath, usually paired with anxiety. But there's no wheeze, no cough. All the cardiopulmonary lab results come back completely normal. It's a condition so incredibly frustrating and ambiguous that it's earned a highly relatable nickname, the IBS of respirology. Patients end up getting over-investigated, test after test, without finding a physical cause. It just goes to show how complex the sensation of breathlessness can actually be.
Let's transition from that unexplained mystery to a very real, stealthy, and dangerous issue, spotting a pulmonary embolism, the silent threat.
To catch this silent killer, doctors rely on a massive mnemonic device, thrombosis. They're mentally ticking off classic risk factors, things like recent trauma, long travel, hypercoagulable states, older age, birth control, surgery, or sickness. It's a huge list. But interestingly enough, while varicose veins are definitely a risk factor for forming clots, those specific types of clots are actually way less likely to embolize, meaning they rarely break off and travel up to the lungs. But here is where it gets genuinely scary. A staggering 20% of pulmonary embolism patients will show up with absolutely zero identifiable risk factors. None. No recent surgery, no long flights, nothing at all. This is exactly why emergency docs have to stay incredibly vigilant. They can't just rely on a patient's history. They have to depend on rigid diagnostic criteria to catch it.
And that brings us perfectly into the PE diagnostic toolkit where doctors start checking the deep systems.
Because pulmonary embolisms can be so incredibly elusive, physicians use strict scoring systems like the famous Wells criteria. Basically, higher points mean a higher pretest probability that a dangerous clot is hiding in the lungs. So, if you have signs of a deep vein thrombosis, like a suspected clot in your leg,
or your heart rate is over 100 beats per minute, your score shoots right up. This objective math is what guides the doctor on exactly which test to order next.
But what happens if you score low on the Wells criteria? To avoid blasting a patient with unnecessary and potentially harmful radiation from CT scans, doctors use the PERC rule, which they remember with the mnemonic "had clots." If a patient is already deemed low risk and they don't have any of these 8 specific features, say they're under 50, their oxygen is above 95%, heart rate is normal, then boom, no further testing is needed. The clot is officially ruled out. It is a brilliant, totally safe way to clear patients quickly.
Now, if further testing is needed, they might order a chest X-ray. While about 75% of PE patients do have some kind of X-ray finding, doctors are sometimes hunting for very rare, uncommon visual clues. We're talking things like Westermarck's sign, which is a localized area of abnormally clear lungs, or Hampton's hump, this weird wedge-shaped shadow. They aren't common at all, but when a doctor spots one, major alarm bells start ringing.
An ECG can provide even more hidden clues. Mostly, they're used to rule out a heart attack. But in a PE patient, an ECG might show a fast heart rate, or the famous S1Q3T3 pattern. What's really fascinating, though, is if they spot flipped T waves in both the anterior and inferior leads. That is a highly specific, very rare sign that a pulmonary embolism is literally straining the right side of the heart.
Now, what's really interesting is how this whole process changes for pregnant patients. You see, pregnancy requires a highly specialized, step-by-step verification pathway. Standard blood tests like the D-dimer just aren't useful because those levels naturally spike during pregnancy anyway. Instead, doctors check the legs for clots first. If they absolutely need to scan the lungs, they start with a simple chest X-ray. If that's normal, they pivot to a V/Q scan instead of a CT scan, which hunts down the clot while exposing the patient to way less radiation.
Once the verification is complete and a clot is actually found, we enter the final phase, treating pulmonary embolisms, which involves some incredibly high-stakes decisions.
This is where the ER team faces a massive, critical stratification line. A massive P causes a terrifying drop in blood pressure, or even pulselessness. For this, they have to go in hard. Immediate thrombolysis, which are powerful clot-busting drugs to save the patient's life right then and there. But a submassive P? That's a lot trickier. The blood pressure is stable, but the heart is still straining. In these cases, experts generally say to hold off on the heavy clot busters, opting for standard blood thinners instead to avoid dangerous, sometimes fatal bleeding complications. The medical triage system is just this incredible high-pressure balancing act. Between listening to the pitch of a rough breath, calculating risk factor algorithms on the fly, and hunting for rare shadows deep in the lungs, emergency doctors are performing a brilliant, high-stakes security verification on the human body every single day. So in a rapidly crashing patient, can you systematically verify the silent, hidden blockage before time runs out? The next time you take a deep, effortless breath, just think about the immense, split-second diagnostic funnel your doctors use to keep that airway clear. Thanks so much for exploring this with me.